So hello. We are here at the EMA meeting, the 15th EMA meeting here in Vienna. My name is Heinz Ludwig. I'm a medical oncologist, hematologist, working at the Wilhelminen Cancer Hospital in Vienna. And my partner here is Professor Niels van der Donk. He is member of the Free University Medical Faculty of Amsterdam.
I think we now discussed two very interesting groups of antibodies. On the one hand, the CD38 targeting antibodies, and we not only have daratumumab, but we will probably also have in the future others like isatuximab and MOR202. And we discussed elotuzumab. But I think another very interesting group of antibodies are the antibodies that neutralize PD-1 and PD-ligand 1. And Heinz, what is your opinion about these checkpoint inhibitors that are evaluated in myeloma?
So the checkpoint inhibitors have shown fantastic results in melanoma and other diseases. And in myeloma, it is hoped that the checkpoint inhibitors will be particularly efficient in patients with high-risk disease, with late-stage disease, because there's more cytogenetic abnormalities, which may lead to more new antigens, if you want, tumor antigens which are expressed on the myeloma cell. So they should be very effective there. And so our hope is when we take the break out of the immune system, that the immune system can then tackle the myeloma cell more efficiently. And as indicated by you, the ideal combination could be a checkpoint inhibitor plus an antibody against one of the myeloma antigens. So may I ask you, what would be your personal preference? Would you use a checkpoint inhibitor plus ALO, or would you use a checkpoint inhibitor plus a CD38 antibody? What would be your preference?
I think now we have strong data that a checkpoint inhibitor plus an IMID is a very powerful combination. So the Spanish group has demonstrated powerful pembrolizumab lenalidomide combination in pretreated myeloma, even giving a high response rate in the lenalidomide refractory subgroup, indicating that lenalidomide really works via activating the immune system. And the Americans, Badros, have shown a pembrolizumab pomalidomide combination, which is also very effective in double refractory patients. But as suggested by you, I think that also in the future combinations of checkpoint inhibitors and tumor cell surface targeting antigens, that these combinations of antibodies can also be evaluated. For example, a combination with a CD38 targeting antibody, daratumumab for example, which increases T cells, and then with the checkpoint inhibitor, you may be able to also activate them. And I think those combinations, maybe also with a third drug like lenalidomide or pomalidomide, these combinations may be very promising. However, we really need to wait for the results, because we are now hypothesizing.
Yeah, but studies have been initiated and are already activated, so we'll have the results probably next year, the year after. So, but of course, we are still very optimistic that the combination of two antibodies plus an IMID plus DEX will be the way to go in the future. At least in other cancers, for instance, in breast cancer, we have already shown, and we use that two antibodies plus conventional therapy improves outcome. Yeah. So it's likely, but we, as you said, we have to prove it.
Yeah. And I think there are many other immunotherapeutic developments ongoing, and we discussed now the antibodies targeting checkpoint inhibitors, cell surface antigens. Which other development do you think will be promising for our patients?
There are the bispecific or trispecific antibodies, and those may be even coupled with a toxin. And of course, hematologists and oncologists would love to have such drugs available as important tools, because it would be easy. You just take them from the store. It's not so complex as compared to CAR T cells, where you have to introduce the antibody construct as a vector. And that is much more cumbersome, and but we have to wait for the results. But I think bispecific antibodies which are pegylated, or trispecific antibodies which are pegylated and which are conjugated to a toxin, they should be very active. We see the high activity in ALL, so there is good reason to hope that they will be active in myeloma as well.
Yeah. I think we are now getting many more immunotherapeutic approaches in myeloma. So I think it will also be very important to look at biomarkers to see which patient subgroup will benefit from which treatment.
But Niels, sometimes the questions pop up. You have excellent activity of nivolumab, for instance, in Hodgkin's disease. But in myeloma it may be different because the immune system is failing or is suppressed. More suppressed. Mm-hmm. So what is your notion here? Yeah.
That's a very good question. And we can only hypothesize. And we know, for example, in Hodgkin's disease that there are typical translocations in which there is overexpression of PD-ligand 1 because of activation of certain pathways. And also maybe EBV, the infection in Hodgkin's lymphoma, plays an important role in upregulating PD-ligand 1 and making it thereby maybe susceptible to monotherapy with checkpoint inhibitors. In myeloma, the immune system is worse. There's an increase in suppressor cells like Tregs. So maybe there you need to combine a checkpoint inhibitor with something else, like an IMID.
Yeah. You mentioned elegantly today that daratumumab also reduces or inhibits Tregs. Mm-hmm. And the day before we had a wonderful presentation as well from Irene Gabriel. She used a mouse model where she knocked out Tregs. And when you knock out the Tregs and the mouse model is transfected by myeloma cells don't grow. Mm. So by eliminating or reducing the activity of Tregs, we may modulate the disease significantly. So one could even think about, apart from daratumumab, which targets Tregs, to develop additional antibodies which target strongly or have a high affinity to Tregs to change the immune environment and to support the stroma to control the tumor cell.
Yeah, I agree.